I'm honored to be selected by the leadership of the OHTS group as one of the three co-chairs to present the results of the 20-year follow-up, the incidence and severity of primary open-angle glaucoma. I have financial interests, but none of them are directly related to this presentation. The OHTS study first reported the results of follow-up that was accumulated between 1994 and 2002, randomization in patients with ocular hypertension who did not have disc or field loss fell into two groups, those that received medical treatment and those that were observed. The initial report concluded that there were 44 members of the medication group who converted and 104 in the observation group. The phase 2 results were reported following follow-up subsequent to March 2009. The number that converted were 71 in the medication group and 60 in the other. The OHTS 3 results that I am presenting today will describe those patients for whom an endpoint could be ascertained, 545 in the medication group and 533 in the observation group. There were 488 patients that represents the cumulative incidence of open-angle glaucoma development, and 493 patients who ultimately died. The results of the phase 1 and 2 OHTS study are shown here. Early medical treatment reduced the cumulative incidence of primary open-angle glaucoma. The absolute benefit of treatment was greatest in patients who were at highest risk. And then thirdly, there was little absolute benefit of early treatment to patients who fell into the low-risk group. Phase 1 concluded that the incidence was nearly 60% lower for those in the medication group. The hazard ratio at 60 months was 0.40. However, in phase 2, the incidence of open-angle glaucoma between the observation and medication groups was not different, with a hazard ratio of 1.06. Well, the specific goals of OHTS phase 3 were to first determine the 20-year incidence and severity of open-angle glaucoma. Secondly, to develop a 20-year prediction model for conversion. Thirdly, to develop a prediction model to identify those patients who were at highest risk for rapid progression. And then lastly, to associate quality of life issues with, or measurements with, clinical findings. Due to the constraint of time and the ability to analyze data which has only recently become available, I will focus on the first aim. The 20-year demographic data is shown in this slide, and it is impressive when you look at the age at the time of ascertainment in the medication and observation groups. They are not statistically significantly different. Furthermore, if you look at the proportion of male and female, there was no difference. Among those of race or ancestral characteristic, Black, Hispanic, white, non-Hispanic, and other, the proportions were virtually identical. There was no suggestion of a selection of follow-up in either the medication or the observation group based on these demographic findings. If we looked at the intraocular pressure at the time of ascertainment after 20 years, the mean pressures are not statistically significantly different. The vertical cup-to-disc ratio between those in the medication and observation group are essentially the same, and the logmar of visual acuity was essentially the same, which suggests the patients who were followed in both groups at the time of ascertainment did not have any significant difference. It should be noted that if a patient died within 2 years of the completion of the study, the information that was obtained within 2 years prior to their death would be included as an endpoint. The mean deviations at the time of ascertainment in the medication group, whether the mean deviation was looked at or the pattern standard deviation, were also comparable between the two groups. The cumulative incidence of open-angle glaucoma continued to increase There was a relatively linear increase in the cumulative incidence until year 15, and afterwards there appeared to be an upward tick. The rationale or reasons for this are still not completely understood and are the subject of further investigation. Of those patients, representing 26,350 person years, 201 developed open-angle glaucoma based solely on changes of the optic nerve. 64% developed these changes in one eye, and 36% had changes in both eyes. There were 287 who had visual field changes with or without corresponding disc endpoint confirmation, and approximately 2/3 had changes in one eye and 1/3 in only one eye. If we look at the cumulative incidence of open-angle glaucoma from the most recent report at 10 years to the 20-year follow-up, the two curves appear to be parallel, and there does not appear to be any convergence. However, both are increasing at what appears to be comparable rates. If we look at ancestral characteristic, that is to say patients of African American ancestry, there was not only a higher cumulative incidence of open-angle glaucoma, but the rate of increase also appeared to increase at a slightly greater rate between the 10-year and 20-year follow-up. When adjusting for the variable follow-up time and looking at those 5 baseline risk characteristics which define the 3 tertiles based on the central corneal thickness, pattern standard deviation, age, IOP, and vertical cup to disc ratio, all of which were used to analyze previous data, there was clearly a spread. Patients in the lowest tertile had a little more than a 20% increase of developing change after 20 years, and those in the highest tertile had a rate which was in excess of 50%. The subject of how ancestral characteristic or race or family history interact with this in the past fell out when corrected for vertical cup to disc ratio and central corneal thickness. Whether or not they will reemerge or be found to be important in later studies remains to be analyzed. In conclusion, the reports for 20 years incidence are presented today. However, the risk factors for conversion and progression are still the subject of intense investigation, and the impact of primary open-angle glaucoma on the quality of life and the associated clinical findings are yet to be determined. Thank you.